Okay, cool. All right. So we're doing an Achalasia patient here with type 2 with a plan for poem, a standard poem. So this patient has uh, just squamous columnar junction is at 44, 45 centimeters. So I like to come back about 10 centimeters proximal to it at 34, 35 centimeters in this case right here. And we'll plan to perform a submucosal injection at 5 o'clock along the posterior wall. So we sometimes can use red dichromatic imaging in these instances to find an avascular access point to avoid any bleeding during the initial incision. All right, okay, out. This is avascular area here. Okay, inject here. Okay, good. All right. Okay. So you want to differentiate between submucosal injection and a mucosal bleb. You was there yesterday. The bleb looks different. This is a proper submucosal injection. How much cc? 10 cc. So we can do about 15 ml. And then we'll stop. Done? Okay, stop, back. All right. So it's a good bulge. I don't see any big vessel here. Yeah. Let's see with RDI. Yeah, so much better now. You can see the vascular pattern quite well. Okay, scope again. Okay, out. Okay, chalo. So I like to be superficial when I'm cutting. You don't want to put it too deep because triangular tip knives are very deep actually. So get a respectable long incision. Okay, stop, back. Now that worked well, no bleeding. Now we switch back to standard imaging. All right, okay, scope pakado. Yeah. Yes, okay. Now tunneling myotomy, out. So we switch to tunneling myotomy. Settings with a precise sect of 4.5, which works very well for dissection. It's AI mode, which tends to pick up the right settings based on the location of the knife. Okay. Okay. So we do a little bit of submucosal dissection in the base before getting the tunnel entry. And the other thing to do is do a little bit of dissection around the edges. Out. Almost feel like the bulge is outside, no? Back. All right, perfect. So, out. So now that we are inside the tunnel, we keep dissecting along the muscle layer. Okay. Back. पकड़ो. I'll try to burn this one out. Okay. Trying to save time. Okay. Pedal. Water pedal. Yeah, no, it's okay. Back. Okay. Inject. Stop. Inject. Nice. Inject. Okay. Clear this. 1 second. Boss, what's the problem? Change the knife, no? Give me a needle until then. Yeah. Out. Inject. Yeah. So this is actually a good appropriate color of methylene blue. So this is how you ideally want it. You don't want it. You can do a little light than this, but not darker than this for sure. More injection. And always be generous with your injections. Never really a downside of putting more injections, you know. Okay. Stop. Back. Coag is ready now, just in case. Out. इसको पकड़ो. A better angle, yes. This is pretty good. So this is a standard classic expected stuff. No fibrosis here. Nice injection. We can go about dissection very smoothly. Back. Try to avoid this one. Yeah, okay. Out. Do you guys see much Achalasia in Italy? Simone? Do you guys see much Achalasia in Italy? Achalasia? Okay. Balloon. Oh, I see. Okay. But did you see enough cases or not much? Not so much, yeah. Right, of course. But sort of standard practice, not so much Achalasia. No, India we see a lot of Achalasia. It's highly prevalent. Okay, back. Inject, yeah. Yeah, much more Achalasia, right? I mean, most of the people, busy practices see at least one a week, almost. Yeah. Oh, you guys have a lot of Achalasia. Oh, interesting. Okay, out. Okay, so I've reached 42, so I'm sort of closer to the G junction now. So I think one thing when you're doing it is obviously to have a nice dissection in narrow spaces out. Do a proper dissection because you may have trouble getting the scope in further, you know. So this case here, sometimes your scope seems to be going in, but when you are in a very narrow space, a dissection done proximally properly is also very important. All right, so now we are here. Let's see. So this one vessel I'm going to avoid. First, I'm going to do a little bit of skeletonization, which is doing a little bit of dissection around it, which is here. And we could probably tackle this with a standard triangular tip knife and this. I may just do coag grasper just because it's, these are the penetrating vessels here. These very classic two vessels you will find at just above the G junction. Back. Yeah, can you get me a coag grasper? These are all arterioles, so they will have high propensity to bleed. So to be on the safer side, just coagulate them. Open, close. So use a force coagulation setting 5 in this, which seems to work well for our coag grasper. Okay, open. Do both together. Close. And the blood supply comes from the muscular layer, right? So you want to ensure that the coagulation is done close to the muscle and properly. Okay. CO2 बंद हो गया. All right, fine. Inject. Keep injecting. So we are at 42. So maybe another 2 centimeters and we are at squamous column now. Put a light कर दे इसको. It's a little dark. Okay, stop. Yep. This is actually not a tough case because the G junction doesn't seem that bad. When it's tight, can be very, very narrow. We'll see. I anticipate it should be okay. Not. All right. Okay. More vessels. Double. Second set of penetrators now. Okay. Pakdo. Okay. All right. Back. Coag grasper. So usually what's been recommended or suggested is that once you encounter the penetrators, you want to be dissecting on the right of the penetrators. The idea being that you're avoiding the sling fibers which help in the reflux mechanism. One study hasn't shown much difference, but it's a more theoretical suggestion. So I think I do try open. If possible, I do perform the dissection on the right. Close. Yeah. Open. Close. Open. Close. Hope there's no life in there. Okay. Okay, nice. All right. So let's see. Inject here. Yeah, now there'll be more and more vessels along the gastric side now. Okay. Keep going. Okay, stop. Out. Okay. Back. Okay, 1 second. I think I can avoid the right vessel. I have to take the middle one. Coagrasper. Mark नहीं है क्या? Oh, it's here. Okay, open. Close. I think I may just take care of this one. Open. Done. Yes. Okay. Close. Nice. Open. Close. Okay. Inject. Okay, stop. Alright, hold it. Yeah, out. So the gastric side, be a little more careful. So have more gentle dissection, because you may not sometimes see the vessels in the background, and not uncommon for bleeding to happen suddenly. See the gastric, these palisading vessels. Hold it. Alright. Yeah, I think we are good. I think if we cut till here, we'll be in a good spot. Yeah, back. Okay, so quiet grasper. So this is sort of where the G junction is, squamocolumnar, and then we are about 2-3 centimeters in, which should be fine. Open. Close. Open. Close. Okay. Inject. Okay, stop. Out. All right, I think. Okay, good. Nice. So, perfect. I'm happy. Back. All right, so now at this point I inject at the end after my tunneling is done. So I leave a little bit of injection to confirm our assessment from the gastric side. Now that we are done, we are at the CJ here. And let's see, let's come back here. Let's do a retroflex view. And we see the nice blue submucosal injection there, right? So that's good. I think we are fine. So now we will switch to myotomy. Take out the air. Patient's okay, man? CO2 is fine? Yeah, good, perfect. That's good. All right. Okay. Okay. Let's get the TT knife. Yep. All right. So 45 is sort of where we said, right? So say we could do, I'll say 37, a little bit down. Yeah, this is fine, right? So 44, 4 plus 2, 3. Yeah, this should be fine. Out. All right. All right. So you can go layer by layer like this with triangular tip knife. But I do like to use the insulated tip knife later at the G junction. IT knife, yeah, back. I think this causes a little more bleeding. That's my feeling. I don't know. Out. Pakado, yeah. All right. Okay. Ready? Chodo. We almost finished the entire myotomy in one go. This is good. Okay. Out. Yeah. Wait. Pakado. Out. Yeah. Chodo. Ah. So you see there are more vessels here, so be a little more careful when you are dissecting in this area. There you go, right? So now we see the fat, which confirms that we are in the peritoneum. So we are 100% in the gastric side over there. And right, there you go. So yeah, 47 to 3 centimeters on this side, almost complete myotomy. And here we are. Where's this? 38, okay. So 10, 11 centimeters in. So I'll make sure that we take care of some of these fibers. Actually, give it back. Okay, open. So we don't need to do this necessarily because these are all longitudinal fibers and you obviously don't need full thickness. You can do with circular and you're fine. But this ends up being pretty okay. I don't like to leave fibers in there. Yeah. It's great. Yeah, good. Good. Yep. All right, nice. We have enough area to sandwich in between. to prevent any, leakage. So good. Scoop going very smoothly. Good, done. So let's put some clips and out. Clips ready? Okay. Sorry, open. Yeah, okay. Open nicely. Go for it. Yep. Very nice. Okay, cool. Turn around a little bit. Clockwise. Yeah. Okay. Stop. All right. Nice. All right. Okay. So, yeah, we can get the first clip a little distally, which is say somewhere. Yeah. There you go. Okay. Close. Close. Okay. Deploy. There you go. Yeah, it's the anchor. It just gets the orientation right. Now, I think, do a little more mucosal incision than usual, but I think it should be okay. It's just smooth, straightforward case, so it's fine. Okay. All right. Open. Yes. So you have to give him enough space to move it. Yeah. Go ahead. Yep. All right. Nice. So there is a technique to these clips. It's not like a standard, closure. All right. Close. Deploy. Not happy. Got a little more on the right, but it's okay. It's not bad, but could have been better. Okay, good. All right, open. Yes. Yes, come on, open. Yes, very nice. No, wait. Open. Yeah. Okay, pakdo. So the correction is what you want to do ideally. Just get a little bit on the left to compensate for that second clip. So this is what I'm going to try to do here. Okay. All right, ready? Suction. Like suction. Close. Yeah, good. Let's see what. Yeah, good, not bad. So we've corrected it partially, I'm sure. I mean, I suppose I could put a clip between the second and third, but by and large it's close. But get the fourth one and then the fifth one we'll keep between the two and then done. Okay, open. Okay, turn. Perfect, good, very nice. Yeah, okay. Oh, sorry. Okay. Close. Deploy. Perfect. One more. Then out. Open. All right, turn clockwise. Stop. Yeah, good, stop. No. It's a little more than I need, but okay, let's see. Hold it. Scope, hold, scope, hold. Turn the counterclockwise, yeah. Counterclockwise. Thoda sa, little bit. More, counterclockwise, yeah. Okay, stop. See, not bad, I mean, it's not too bad, but okay, close. Close. Perfect, deploy. Yeah, good. This is fine, fine, fine.